Hello and welcome to the 4th BJ Psych Virtual Journal Club, co-hosted today by the University of Edinburgh. So I'm Angharad. I'm an adult psychiatry registrar and also a trainee editor of the BJ Psych. And I'm delighted to be chairing this journal club for everyone, along with my co-chair from Edinburgh, Lucy Stirland, a clinical lecturer here. So please be aware this session will be recorded and may be shared afterwards. So 2 trainees today will be presenting a brief appraisal of our journal club paper today, which is real world effectiveness, predictors and onset of action of anti-dementia drugs. We'll then hand over to our resident panel of experts. So that's Professor Graciela Muniz-Ferreira, Dr. Katrina Davis and Dr. Tom Russ. And after hearing their views on the paper, we'll be able to hear from the first author on the paper, Dr. Nemanja Vatsi, and then open it up to questions from the audience. So before we move on to the journal club itself, just a few housekeeping notices. Please do follow and add to live tweeting of the journal club using the hashtag BJPsychJC, which will be popping in the chat. And as we've mentioned, for your information, we are recording the webinar. Any questions you have for the speakers or panel, please do feel to put them in the Q&A tab, please, as you think of them, and then we'll collate them and put them to the panel during the audience Q&A section. So now over to you, Lucy, for an introduction to today's appraisers.
Thank you, Angharad, and welcome everybody on behalf of the University of Edinburgh Division of Psychiatry Special Lecture Series. We've got a great lineup of speakers and panellists today. Presenting the paper, we have Dr. Donncha, who's a ST5 Old Age Psychiatry Registrar in East Lothian, and Dr. Donncha Mullin, who's a PhD student at the Alzheimer's Scotland Dementia Research Centre and Honorary Old Age Psychiatry Registrar. So without further ado, over to you to present the paper.
Thanks, Lucy. So I'm just going to whiz through this introduction. So this is just some of the panel to introduce you and just an outline of what we're going to discuss today. So I'll go through the introduction and background, then I'm going to hand over to Donncha, who's going to take us through the methods and results. I'll speak a little bit about the discussion and then we'll bring it back to the panel for the main discussion. So just then some background information before we get into the nitty-gritty of the paper. So the clinical condition that we're going to speak about today is, of course, dementia. So for those of you who are unfamiliar, dementia is a neurodegenerative condition associated with progressive cognitive and functional decline, the most common cause of which is Alzheimer's disease. Treatments are unfortunately very limited, with no disease-modifying agents currently available. In the UK, we do, however, have access to 2 different types of treatment for the cognitive symptoms specifically of dementia, and it is these medications that are the focus of this paper today. So the first group is called the acetylcholinesterase inhibitors. Sorry, I'm just going to go back. Of which there are 3 types. There is donepezil, rivastigmine and galantamine. Sorry, the slides are going all over the place on my screen. Sorry, so I'm just talking about the medications themselves. So acetylcholinesterase inhibitors, they work by trying to counteract the cholinergic deficits seen in patients with Alzheimer's disease, and they have been in use in the UK since the late 1990s. The alternative available is memantine. So this is an NMDA receptor antagonist that works by reducing the glutamatergic overactivity seen in dementia in an attempt to try and slow associated neurotoxicity. So it was introduced slightly later in the early 2000s. So both of these medications have been in use now for some time, although the guidance for their use has changed somewhat over the years and has often been tied to controversy over just how effective they are and which groups of patients should receive them. So this controversy was brought into the spotlight in recent years, back in 2018, when the French government decided to withdraw the funding for these drugs based on the basis that they had insufficient clinical benefit. Okay, so what are the current guidelines then in the UK for these medications? So as we can see in this slide down the left-hand side, NICE tends to have a focus on severity of illness to help to guide which medications should be used and when. And when we're talking about severity of illness, we're talking about how well a patient performs on formal cognitive testing. And this is mainly done by a certain test called the MMSE. So for those of you who are unfamiliar, the MMSE is a common 30-point cognitive assessment tool. However, it is not the only cognitive assessment tool. There are many, many more that are used in common practice. One which is used very commonly, which is worth mentioning, is something called the Montreal Cognitive Assessment Tool, or the MOCA. And the reason I'm mentioning these two specifically is that you'll see this paper uses them in their outcomes. So these tools help to guide us on the severity of illness, which then helps to guide treatment choice. So importantly, this slide, it shows the guidelines for Alzheimer's dementia specifically. And whilst there are other guidance for other types of dementia, such as Lewy body dementia and Parkinson's disease dementia, which can benefit from these medications, there are other types of dementia for which they are not recommended, such as vascular dementia or frontotemporal dementia. Okay, so what evidence exists to help these guidelines be in place? Well, like any kind of intervention, the gold standard is a randomised controlled trial, of which there are many now for both of these medications. And what the RCTs consistently show is small but statistically significant improvements in cognition over the first 6 months of treatment. So to put that into context, a recent Cochrane review of donepezil specifically pulled together lots of different RCTs and showed a mean difference of 1.1 points on the MMSE between treated and untreated groups at 6 months. And remember, this is a scale of 30 points in total. So RCTs are, of course, extremely useful, but they have strict inclusion and exclusion criteria, meaning that trial populations are not often representative of the patient populations that we encounter every day in clinical practice. So whilst this evidence tells us about the efficacy of the drug, it doesn't provide evidence for the real world effectiveness in real populations where a number of confounding factors are at play. So how can we assess this real world effectiveness? Well, researchers are increasingly using large data sets from real-life diverse populations from sources such as electronic health records. So across the UK and the world, there is increasing use of these electronic health records, which provide a vast data source. And on top of that, there's advances in both computer and artificial intelligence techniques, which allows for easier extraction and analysis of these potentially vast data sources. So there are a number of research databases that have been set up with this in mind, one of which is the UK Clinical Record Interactive System, or the UK CRIS, and it is this database that our current paper utilises. So UK CRIS takes into account 15 different NHS mental health trusts in the UK, and I believe there were only 12 involved at the time of the paper. This database aims to accelerate research into dementia and mental health specifically. It's regulated with secure access to authorised researchers for patient data extracted from the electronic health records of the real patients from these real health trusts. So in terms of the aims of the paper then, it aims to use this large-scale electronic health record data to investigate the real-world effectiveness of both these acetylcholinesterase inhibitors and bimantine. And the question is, can the results from the RCTs be replicated in this real-world population? And if so, what factors predict this effectiveness? So now I'm going to pass you on to Donncha, who's going to talk us through the detail of the methods and results.
Okay, great. Thank you so much, Cinzia. I'm going to just get back to the slides here and let me know if they're not being shared, as we're just running through this ourselves. So, as we mentioned, this is a retrospective cohort study, real world study. There were 24,000 patient records, so the electronic patient records of 24,000 patients, and that's about 3.7 million documents in total were in use in this study. And that number, I found it a little bit hard to to find, actually. So I would have maybe been more upfront with that, because it's a great big number and it's a key part of this study. So I would have had it in the abstract, or maybe even in the title. In the final structure data, there were around 7,500 people with dementia and MMSE scores. And there was around 24,000 MMSE scores in total for those patients, and just over 4,000 with dementia and MACA scores, and almost 9,000 MACA scores. This is another study that's closely related, asking a very similar question, but on a smaller scale, and it was back in 2014. It was by Guyan Pereira and Robert Stewart et al. And this was, the conclusion of this study was that, similar to randomized controlled trials, cognition stabilizes for 6 months after acetylcholinesterase inhibitor prescription. Now, I want to spend a bit of time on the models at play here, because they're what make this study so interesting. And they're actually, when you read through it, what the outcomes, the conclusions, everything in the study is based on is the model that's designed. Now, George Box is a statistician. There's a nice photo of him, I thought, that coined the term. All models are wrong, but some are useful. And that's really helpful, because we're not looking for a perfect model. There's no such thing, really. But as long as it's valid, reliable, it's measuring important things, and it's helpful for us, well, then possibly it's a useful model. So the goal is to see, first of all, is this model a useful model before saying, oh, well, these results are reliable. And the way this paper was laid out, we had to dig into the supplementary materials for that. Now, I don't know where the reasoning for that was from, but it could be from a number of sources. So it's not necessarily a critique at all. But when you do go into them, you see that it was a natural language processing model that was designed. Now, we're all probably familiar with these, even though we may not necessarily know it. So if you've ever used a chatbot assistant on any website or that, and some we know are better than others, you'll have used it. That's a natural language processing model. So the goal of it is about making a model that's capable of understanding the contents of your text, or of documents in this case. And that should include the contextual nuances of the language within them. It's no good if it needs to be exact words. And then once you've designed this model, it should then be able to accurately extract information from patient notes in this case. And the information that it was asked to extract were 3 concepts. Now, before you can have a model, you need to have a gold corpus, as it's called in this, a gold body of work to compare the model and that the model can learn from. And in this case, that model development, again, it's in the supplementary tables, was from 2 clinicians. There are 2 clinicians on the authorship panel of the paper, and they looked through 600 documents of 360 patients. And they went through them and they determined the diagnosis, and that was whether it was Alzheimer's, vascular dementia, mixed dementia, Lewy body, or mild cognitive impairment. So they looked for all that, and that could have been from ICD-10 codes, so little number codes that signify a diagnosis, or mentions of dementia in the notes. They then also looked for the different dementia medications that have already been discussed, and they looked for mentions of MMSE or MACA and their scores. Now, for each of those concepts, the authors needed to know when, because time is a huge part of this paper, they needed to know when these concepts were being assigned, and then by whom. So was this diagnosis being given to the participants' carer, because that's relevant, because then we can't count them. Was it being given by a GP? Was it a diagnosis just kind of being hypothesized? So all these things needed to be factored in, and the same for the medications and the scales. And then they checked to see how much they agreed between each other. So there was the 2 clinicians, and they did what we call inter-rater reliability tests. Now, that's what's on this next slide, is the actual scores. I've blanked out some of the less relevant. But if you look at the gold box here, the human F1s, the F1 is just the summary score of how much the 2 clinicians agreed with each other. So you can see that 95% of the time they agreed on diagnosis, 96% on medication, and every single time on the scale being used. And that's in comparison with the overall F score, which is an overall performance score of this natural language processing model, which was closer to 93% on diagnosis, 98% on medication, and didn't do so well on the scale, 82%. But overall, I think in summary, and having looked through the supplementary tables, the natural language processing model did pretty well, and it captured about 90% of the 3 concepts of interest. So the model is okay, and it's all available. So the OR code, OR is a computer language for writing code. It's all there. So if you know how to use OR, you can go on and you can download it and you can do this study yourself, which is amazing. And this is a big part of open open research, and this is the open science framework where you can just log on and get all this information, including the actual natural language processing model itself. And that's a really brilliant thing for science. Now, the statistical analysis methods in this are a thing called generalized additive mixed effect modeling. I'm not going to go into too much detail, but I think it's at a level that I hope most people can follow here. And the key things for it is that it's data driven rather than sort of intuition or experience. And it's an ideal modeling method for estimating non-linear changes in, for instance, in this instance, MMSE and MOCA scores in relation to the time point of medication prescription, as well as the effects of switching between medications. So the reason I'm saying non-linear changes is that you're probably more familiar with this type of model, which is a linear model. And on the bottom here, the x-axis, so that this sort of the floor of it, you'll see the numbers 100, 200, 300. As you work your way up these, if you draw a line up where you meet this other blue line, that'll tell you roughly, it gives you a rough idea of where someone will be on this other scale here on the y-axis or the up and down axis. So in this way, there's a linear relationship between all these dots that if you know what one of these scores is, you can get a fair idea of what the other one is. Another model that we might be familiar with is a logistic model. So you can see how it's a curve, and as you approach the top, that curves around more, so it'll never actually get to the top there. But you can see there's still a relationship here. Now this is a generalized additive model, and you can see the nonlinear relationship. It's not a straight line, but it retains explainability, even though it's not a straight line. The mixed effect component here just refers to how the model itself contains both fixed and random effects, and that has some advantages in dealing with missing data, and which I'll mention later, and non-independence in the data. So say the patients here are sampled all from within 2 trusts. Okay, so the last bit on the data analysis, where any model needs to be, you need to take into things that might be confounding that or influencing it in a kind of a bad way. So you need to factor in the age at cognitive assessment, the gender and the duration of the dementia, because we know all these things affect the outcome. So we don't want to be just reporting on those when what we think we're reporting on is actually the medication. And they could adjust for those. However, they didn't adjust for a couple other things, and they were upfront about that, and that's fine. That's all good science. That ethnicity and marital status was not accounted for because there was a lot of missing data there, not enough variation. So the questions are, well, why was this data missing? Do the group who had missing data differ significantly from the group who did not? And in that case, then that does matter. And I thought there were other confounding variables that were really difficult to control for in this instance. Things like what dose of the dementia drug were they on? Were they on medications other than antipsychotics and antidepressants? They could capture those 2 classes of drugs, but there's a whole other group of drugs that are an assortment of drugs that people could have been on that would affect their outcomes. And I think importantly, psychosocial interventions alongside the medication prescription weren't factored in or controlled for. And we all know that that's a huge part of any management plan. I wanted to mention the subgroup analysis, and I'll show you some graphs in this because it's a really interesting part of the study. They did it on the MMSE scores because that was the bigger group. If you remember, I think there were over 23,000 MMSE scores versus nearly 9,000 MOCA scores. That makes a lot of sense. They broke up the MMSE, they categorized it into sort of normative cognitive decline. So that's any score 25 to 30, mild, moderate, and severe. And you can see the breakdown here that the authors gave it. That's a little different to how on the MMSE chart itself, it says that the scoring should be, and where they say 24 and above is no cognitive impairment, 18 to 23 mild, and 0 to 17 is severe. And the last point on MMSE is that there's any researcher who uses it knows about this ceiling effect, and that's where there's a limited sort of dynamic performance range for non-cognitively impaired individuals. So that kind of increases the likelihood that those with pre-dementia will score within the normal range. Okay, so this is a really interesting graph. So you can see the non-linear graph here. This is a change in the mini mental state exam score, which is on the up and down axis, the y-axis, over time is along here, in relation to the time point of medication prescription. So that's year 0 on the axis. That's when the medication was started. So you can see here, people are decreasing slightly. I think it's about 1.1 point per year of age. So as we get older, we score less well on the MMSE across the population. Oh, sorry. So that's the decline is happening here. And then what these patients had, those who were prescribed, they had in the 2 years prior to the prescription, this solid line indicates a significant decline, so worse decline than you'd expect just by their ages. And you can see that trend. medication is started, and you can see a plateau. So the cognitive decline is stabilized or even some improvement, and that lasts around 5 months or so. And then the decline is significantly worse than you'd expect just for their age, again afterwards, before petering out. Now, this other graph, the other graphs here indicate the severity subgroup analysis. So this is the group of people who have a diagnosis of dementia but have an MMSE score in the normal range, which is one of the problems with the MMSE. But for these people, once you're started on medication, there's no benefit. So what they found was in this group, the decline was significantly worse. There was no period of stabilization. However, you'll notice that the more severe the medication, as you work down through C, D, and E here, that there's even some improvement in group C and D. I think Cinzia touches on a wee caveat to do with this severely impaired group. So we take these with a pinch of salt, these results. And the authors themselves mention that. So there's another factor that they looked at in the paper was those on monotherapy treatment and those medication switching, and the difference in performance between the two. A little bit on this, because I think some of this was in the supplementary paper as well. The monotherapy treatment were considered in that group, and it made up about 80% of all the participants, if you were on an acetylcholinesterase inhibitor, so say donepezil, and you continued on that, obviously, or if you were switched to memantine, because that kind of follows the NICE guideline pathway. However, if you're switching between acetylcholinesterase inhibitors, for whatever reason, you were considered in this group, and if you're in that group, you tended not to get any benefit. Okay, so the authors felt that overall 68% of participants responded to an acetylcholinesterase inhibitor. So a third actually increased their cognitive score and a third stabilized. And this is higher than the 40% typically reported in randomized controlled trials to date. The authors hypothesized this is possibly due to an unmeasured placebo effect of medication. However, I thought it was possibly more likely this is related to an increase in psychosocial support once you've been diagnosed or prescribed medication. I think it's a direct quote, sorry if not, that medication switches are a sensitive approach to distinguish responders from non-responders. I wasn't so sure on that, and one reason was because the medications, there was only small proportions, only 16% of the overall population were analysed for a response, because to be in that group, you needed to have had 2 MMSEs in order to track a response. And I felt that those without 2 MMSEs likely had poorer cognition, because we tend not to repeatedly do MMSEs on people who have a very poor cognition, and it might also indicate maybe there'd be less compliance with medication. Overall, predictors of a poor response to medication were this lower predictors of response to medication were a lower MMSE score at baseline, leads to a stronger medication effect. We found that the authors found that there was a poor response in females, and you were less likely to have a good response if your MMSE scores were in the normal range. Being on antipsychotic medication, you tended to have a lower average MMSE score and a steeper decline over time. And then those on memantine, because you have more severely cognitively impaired, or those switching medications tended to have a poor response. Interestingly, being on an antidepressant or diabetes medication was not found in this study to have a significant effect on your response. Thanks very much.
Thanks so much, Donncha. So I'm just going to bring it back, just going to mention a few discussion points just to get some thoughts rolling, although I know the panel probably already have a lot of discussion points in mind. So firstly, just having a think about the strengths of this paper, which I think there are many. What stood out to me was the large data set, which I believe is the largest data set for this particular clinical question to date. And secondly, just the methodology in general, that this paper has done what it set out to do, in that it replicated RCT results in a real life population. So it shows this methodology is useful and could potentially be replicated in other areas. And I think, as Donncha highlighted as well, the model has proven to be valid, and they've been very transparent, and that's been published in a public place. So it should be easily accessible for other researchers to do similar things. And Donncha, if you could move me to the next slide, if that's okay. Just then thinking about weaknesses, so like any paper, there's always weaknesses to consider as well. So when we use real life patient data, the results are only as good as the data collected. So there can of course be huge variability in that, often down to the individual who is recording the data itself. So that's something to bear in mind. And as Donncha kind of touched on a little bit there was quite a small comparative group in terms of those who were deemed to have severe illness. So it's harder to draw meaningful conclusions in this group. This may well be related to the fact that this group is harder to engage in cognitive testing, and as well clinicians might feel that repeated testing in the severe group is not necessary. So there are no data in this paper in terms of safety or tolerability of these medications. Now, of course, that wasn't the research question here, but I think that these are often very valid concerns of patients and their carers when thinking about starting new medications. On a kind of similar vein, just thinking about these responders and non-responders. So as Donncha mentioned, we weren't that convinced that this was a good indication in terms of medication switch, indicating that someone is a non-responder to medication. And the reason we say that as well is that often if someone switches from one cognitive enhancer to another, particularly in the early stages of treatment, it's more a reflection of its safety or tolerability. So people developing side effects like cardiac side effects or GI effects, as opposed to a change due to lack of response. So that's something to bear in mind. And lastly, just I wanted to comment on how heterogeneous the population actually is. So there is some missing data on race, but the supplementary data would suggest it was a predominantly white population that was studied. There were 2 health trusts that were included, and both, I believe, are from quite affluent areas. So I question the heterogeneity in terms of the race and socio-economic status as well. And if you could just move me to the next slide, Donncha. So just to try and draw any kind of conclusions before we go on to the panel discussion, and I'm sure they'll have much more to discuss. But in essence, this paper has set out what it has achieved what it set out to achieve, in that it has replicated RCT results in a real world population. This is quite useful when thinking about guiding patients and families in their medication choices. I think that higher overall response rate in that real world population is something which is particularly interesting and could influence practice. But I guess what I wanted to finish on before we move on to the panel is that this research has only given further evidence to what is already a large body of evidence that these medications have only a very modest effect on cognition. So actually, in terms of the overall controversy of their use, it might not actually add anything to that argument. So I think that's all me and Donncha have to say at the moment. So we would pass on to the panel now, if that's all right.
Great, that's excellent. Thank you very much to Cinzia and Donncha. Angharad going to introduce the panel in just a moment, but to the rest of the attendees, while the panel are giving their thoughts, it might be helpful to start thinking about your questions. And if you could put those into the Q&A box rather than the chat, we'll be able to bring those up to the panel afterwards. Angharad.
Brilliant, thanks Lucy. So now we're just going to move on to some thoughts from our expert panel, and we're really privileged to be joined by Katrina, Graciela and Tom to help us put these kind of results in context. So first of all, Katrina. So Katrina Davis currently works at KCL, King's College London, and SLAM, the South London and Maudsley NHS Foundation Trust. So Katrina has a clinical background, but also a long-standing interest in research. And currently Katrina is working on her PhD entitled Co-Prescribing in Dementia, so very kind of topical for today's presentation, which uses population informatics to examine those sort of comparative effectiveness research in multimorbidity. And she's also a member of the data science group at the mental health research charity MQ. So over to you, Katrina.
Hi, thanks for inviting me, and thanks so much for a really clear presentation, and I'm enjoying it so far. Let's see how we get on in our discussion. But I think it's a really remarkable, efficient study, and no one had to set up a large intrusive trial. No one had to come back to see researchers for any particular cognitive testing. It didn't rely on clinicians changing the way that they report anything. No one said you had to fill in this form every time you see someone with an episode. It uses the text that is just produced from day to day in a memory clinic and other clinics in the department. And I mean, that's really great. And I think this is a kind of a demonstration study of what can be done, which is then going to be utilised and taken forward for other purposes. So one of my PhD supervisors is Guyan Pereira, who did the study that was referred to in 2014, which is a very similar study. But when he says there are 2,000 people that he's following, those are 2,000 people who are on an anti-dementia drug and have at least 2 MMSEs. When this paper says it's got 7,400 people, well, 4,700 of those weren't on an intervention drug. So I don't know where they came in the statistical model, but I think from a size, actually, it's not quite as big as it says. And 3,500 of them had less than 2 MMSE observations. And obviously the statistics are really efficient and they're able to make the most of those things. But if you think that you're following each participant, and each participant is both the case and the control, which is one way of looking at this. Actually, that's not what they've done at all. They've plotted all of the MMSEs around an index date and then drawn the line. So yeah, it's really quite remarkable, the results that they've got. But you do have to come back to this thing about routinely collected data only being as good as the data. And yeah, some of the qualitative documentation is difficult. Certainly for my PhD, because I have a lot more time than someone who's just writing one of these papers, I've gone through and looked at the quality of documentation in various different clinics and decided that I have to exclude anyone who was only seen by liaison psychiatrists, because liaison psychiatrists make the most awful notes. And often the MMSEs that you get are MMSEs of that patient when that patient has delirium. And so trying to fit that into a model is obviously going to cause some problems. So there is that. There's also the fact that you're basically looking at a confirmation study. These patients have gone to their doctors and their doctors have decided that they look as though they probably benefit from anti-dementia drugs. And guess what? A lot of them benefited from anti-dementia drugs. So you have to look at who is actually being included and whether they can generalize to the population that you want to talk about. For instance, what I'm really interested in is people who are diagnosed with vascular dementia. We don't generally give those people these drugs, but actually in practice, when the diagnosis is usually made just on a CT or something like that, would these people benefit from the drugs? So we can't tell that with this because they're not generally prescribed them. So the last thing I'll say also is in the Chris Slam, where Guyan Pereira did his reporting, that was the end of an age where the trust, the Slam Trust, looked after people with dementia by keeping them in the memory clinic after they had started medication. Around the same time as Guyan Pereira's paper came out, the trust stopped doing that, and as soon as medication was established, would discharge back to the GP. And so that then makes data collection really difficult. But if you can link to general practice records, or you can go to Scotland. I know Lucy tells me that there's some kind of mandated follow-up period. then we can start following these things. And it's going to be really exciting, taking this up and running it with some juicy clinical questions.
That's great. Thank you very much, Katrina. I think we've got a lot to think about already. I'm going to introduce the next panel member. That's Graciela Muniz-Torrero, who's a biostatistician and epidemiologist who's recently been appointed Personal Chair of Ageing, Health and Methods at the University of Edinburgh and is also an endowed research professor at Ohio University. She's got extensive experience in developing and applying statistical models and methods in ageing and dementia research and in data harmonization approaches. Over to you, Graciela.
Right. Thanks, Lucy. And so I'd like to start by congratulating the authors. I think this is a really cool paper. It's very informative, and I'm, given my background, I'm particularly pleased to see the use of sophisticated analytical methods, and also the integration. It's a very interdisciplinary team, so I think that's a really a very good strength of this paper. The second point that I wanted to raise, that is partly what has been mentioned already, is the how fantastic the opportunity of using real world data is. So this is pretty unique, and again, it goes beyond the more controlled environment of randomized clinical trials. So those are, you know, I thought this was really fantastic to see. So now, from the analytical perspective, and this is where I'm going to focus a bit more, I am familiar with the MMSE, and I think that most people know, also the panelists mentioned this, is that the MMSE has a non-standard distribution. So it has like floor and ceiling effects. And it looks like in this paper, the MMSE was modeled as such, right? It's like in the scores from 0 to 30 and so on. But there have been some alternative models proposed to, if you want, to relax the effect of the ceiling and the floor effect. For example, Tobit models that relax that allow the opportunity, give researchers the opportunity to expand the scale. But particularly for this type of approach, I think that could be an interesting way forward to see whether some of the results that we are seeing here have to do with that ceiling effect. Or the beta binomial model is another way of modeling this type of scale in the, or any scale that has this type of the nature of the MMSE questionnaire data. So that could be an opportunity to investigate a bit further how sensitive the results of the paper are to the potential non-standard distribution of the outcome. I also thought that there were some other aspects that I found interesting. For example, the fact that what the authors mentioned, that after the period of stabilization, the rate of decline is the same as before the medication. And that for me was almost like counterintuitive, because if you think that at some point, like the rate of decline in the MMSE is non-linear, I would have expected some sort of acceleration and therefore a faster rate of decline after that stabilization period compared to the rate of decline before the medication was initiated. There was also interesting, or non-standard, if you want, to adjust for the, in this case, the MMSE at prescription in a model of an outcome that is like the MMSE, for instance. Right? So that's something that is usually not a standard practice. And there have been some publications showing that that could be a bit controversial. And another point that I wanted to raise is something that one of the panelists mentioned, is that the non-heterogeneity of the population. And if these are relative, if the population is non-representative, which is, it happens, right? This is the type of data that we have, is completely normal, if you want. Right? But it could also be, because this is a type of population that perhaps is more educated, And the MSc is also known to be biased towards more educated people. So those are aspects that I thought that I would love to hear the thoughts of the authors. But overall, I thought that it was a really, really interesting piece of research.
Brilliant. Thank you so much, Graciela. And so now over to Tom finally. So Tom Russ is a consultant old age psychiatrist and honorary clinical senior lecturer in Edinburgh, and is also director of Alzheimer's Scotland Dementia Research Centre, and has research experience in using big data to examine these sort of environmental, geographical and psychological risk factors for dementia. So over to you, Tom.
Oh, I just suddenly realised I need to unmute. Great. Well, thank you very much. I similarly really liked this paper. I think it is a lovely application of data science to a really useful and practical question. And it made me think a lot about the therapeutic nihilism that a lot of my colleagues report when seeing people with dementia. Some people do question whether actually there is any point in prescribing a cholinesterase inhibitor or not. And whenever I have these conversations, until recently, I would reach for Pereira's paper from 2014, and now I can start reaching for this one as a slightly larger and slightly more recent one. But one of the huge advantages of Pereira's paper is that they managed in that application of data science to include more patients than had ever been included in a randomized controlled trial of a cholinesterase inhibitor in their paper using routinely collected data. So now we're kind of slightly bigger than that as well. And working on clinical trials, and I'm hugely grateful to all my colleagues who help with recruitment, I know how hard won every single participant is. So ways that can answer similar questions using a different approach are wonderful. It's a very practical application, which I do like. And also, it's very interesting in that the people with the higher levels of cognitive function at baseline benefited less, if not at all. And that fits with the evidence for the use of cholinesterase inhibitors in mild cognitive impairment, which is that we shouldn't be using them because they don't have any efficacy. But it also makes me think back to my first old age psychiatry job as an SHO, when the very rigid, nice guidance was in place, and you were only permitted to prescribe a cholinesterase inhibitor to somebody who scored between 10 and 20 on the MMSE. And that's not a million miles away from the findings of this paper, actually. There is a satisfying confirmation of the fact that actually somebody with a moderate degree of impairment may possibly benefit from this. And the people with more severe cognitive impairment at baseline, I think there maybe are difficulties about the number of people who are included and whether they would be less likely to be followed up. But it was an interesting thing. And I think the weaknesses of it are also a strength, because the weaknesses are to do with what is collected, what data are possible to be extracted from the electronic medical records. But actually, the fact that it is more or less representative of hopefully the general population is quite a strength, actually. Though the missing data kind of is a potential concern for some of these issues. But certainly, I couldn't clarify exactly what the inclusion and exclusion criteria for CRIS in these areas is. But I think I'm right in saying that the South London version of CRIS is opt-out. So essentially, aside from the 3 people who've managed to see the toilet in the downstairs toilet of the poster in the downstairs toilet of the Maudsley Hospital that tells you can opt out, I don't know what the arrangement is, but anyway, very few people will have opted out. So you've got a very representative population, and I imagine it's a broadly similar situation here, which again is a great strength in terms of applying this to the people that I see in clinics on a Friday morning.
Great, thank you very much, Tom. Before we move on to the audience Q&A, I'd just like to invite our the first author of the paper, Namanya Batsi, who we're very pleased to have joining us today, to give his thoughts. So Namanya is a lecturer in psychology at the University of Sheffield and has an extensive background in data science. He's particularly interested in changes in expertise and performance over a lifetime. Namanya.
Hi, everyone. Thank you for discussing this paper. It's a really great opportunity for me to hear all of your feedback and really the views on it. Thank you for the presenters. You did a much better job than I ever did with it. when presenting it. This was so clear that I would need to borrow some of your examples for my next presentations. So I just wanted to give like a general overview of how all of this started. I think that primarily this started when there was this development of the second instance of Chris in Oxford, when people from SLAM separated, and then there was like this instance of Chris in Oxford and in SLAM, and I was not there for that initial developments at the beginning, so I was not there for the conceptualization of the initial NLP model. But I remember some of the thinkings and some of the discussions that we later had when it comes to that. And the idea was primarily to focus on dementia patients, because we were all interested, and this is type of research that we do on the topics in dementia, but then also because there is a level of, let's say, lower noise when it comes to dementia patients. They're going to quite frequently have measures of MMSE and MoCA scores. Those things are routinely going to be collected. Medications are, so to say, there are just a couple of those or few of those, and not like in the case of depression, many different things that could be prescribed. There are also specific type of population that it's a old age type of mental neurodegeneration, and then the textual information that we will find about them will rarely include discussions about other people. Like in depression, you will have discussion of what has happened with the parents. Did they have a depression? If we are talking about like a middle-aged or young adults or something like that. Well, this is not the case in dementia. So it was relatively straightforward how we could think about developing NLP models. And then this is somewhere where I came into the picture, and when I was thinking what could we do with this model that we were developing, Pereira paper was like the first instance. Similar to Tom, this is a paper that I really liked and that I always refer to as something like this is something that we would like to showcase when using real world data, when that we can really replicate the effects from the clinical trials. And we set on to see whether we can replicate the effects from Pereira work and expand it to, so to say, describe the population that we managed to extract, see whether we can quantify additional factors, and so on. So this is the background of the whole paper, and I think that Katrina said it really nicely, that this is a demonstration paper where I think that my main argument when I'm applying for grants to work on this and to get additional time is that electronic health records really give us a window into the population that is really hard to get, especially with the severe type of performance or the severe deterioration. So if you want to expand on what could be potentially beneficial to these patients, probably this is the first place where we can find some instances of things that are working, not because they're necessarily prescribed or necessarily that we necessarily realize that they are working, but maybe we can mine this data and find some patterns that could point towards, or let's check these factors, these behaviors, these treatments in a clinical trial, and whether they are really causally there or whether they're just associations that occur and a random noise that is in the data. But at least in my view, this is a really nice population, a really nice method that we could use to potentially expand the list of potential treatments, whether that is a combination of medication, or whether that is like a psychosocial or behavioral or anything that is there potentially reported and we see that it's working. This could be a nice, so to say, end goal where I would like to take this type of research.
Brilliant. Thanks so much,
Yeah.
Donncha. And thanks also to Katrina and to Tom and to Graciela for giving us a quick summary of your thoughts about the paper. So now it's time to hear from our audience. And so I'm just going to invite all the panelists and speakers to join us for the Q&A session. I'm just going to pass over to Lucy to ask the first question.
Thank you to those of you who submitted questions so far, and we'll take all of them. I see that the first question is from Dr. Neil Anderson. And his question is one of the problems about looking at very large populations that individual variability is smoothed out? So in this study, there may be a small but significant minority who do very well with medication, or alternatively do very poorly, but this response is drowned out and looks as an overall modest response. I wonder whether Graciela might like to answer that one, or anybody else would like to.
Yes, it's a possibility, but I think that even like if you think of randomized clinical trials, that's even a worse situation, right, where things are just compared at the mean level. And I'm looking into subgroups or participant level data could be more meaningful, and that's something that I think that this team is fantastically well qualified to develop some mixed models, for instance, where you can see, whether subgroups of people benefit more or less, even though you have already done that by stratifying the populations. But it would be interesting to see whether that can be explored a bit further.
Thanks so much, Graciela. I don't know if anybody in particular wanted to come in on that question, or whether we can move on to the next one. No, okay, brilliant. Let's move on to the next one in view of time then. So next one is from Guy Holloway. So thanking us for the presentation, saying the paper suggested that drugs were more effective for more severely impaired patients. However, the more severely impaired a patient is, the less likely they are to get repeat MMSEs. So if they do not get a repeat MMSE, they don't get included in the response data. So the paper's effectively selecting responders. So Katrina, I don't know if you had any thoughts about that one.
Yeah, I mean, the way that I understand the curves is that they basically include all MMSEs. So it's not only including people who've got more than one MMSE. So that's the first one. I did want to mention something else I perhaps forgotten in mine. One of the weaknesses about RCTs is they don't include people with comorbidities quite often because they want to purify the effect. But I also found that people who had more comorbidities were actually less likely to be referred to memory clinics. Some of them were going to geriatricians, and geriatricians were prescribing these things. But again, if you're only using the CRIS, which is the mental health and dementia and memory clinic services, you're missing out on these people. So that's one potential kind of weakness there. But yeah, it is definitely where the data becomes a little bit tenuous.
Okay. Yeah, absolutely. And Graciela, you've got something to add there.
No, I was just thinking that from a methodological perspective, I understand that is a problem of informative missing data. So there are some methods that could help to alleviate the potential biases. Although the combination of that type of methods with some of the methods used in the paper is challenging, to say the least, but it's an option of looking into potentially missing, not at random missing data.
Absolutely. And Nemanja, you've got something to bring in as well at that point.
So I can't answer to that question directly. I think that we have in one of the sensitivity analysis that is posted online that we exclude, so the model is only developed or fitted to the participants with more than 2 observations, and but it's not by the subgroup. That's the thing. I can't say for the last subgroup that the pattern stays the same. So I was just checking that.
Brilliant, thank you. And then I think we've got perhaps time for just one more question, Lucy.
Yeah, we'll read out the question from Parvez to Angharad. If the improvement seen for a short period after diagnosis is the effect of increased support and psychosocial interventions that are typically more intense in that initial period during which medications are also initiated, And conversely, does transient stabilization or improvement in cognition have a biological explanation that can be attributed to medications, and how do we know they work, and how we know they work? So that's then a huge question to answer in 1 to 2 minutes. Tom, I wonder if you've got any thoughts.
I'll have a bash. Yeah, so it makes me think that yeah, we're celebrating everything about Scotland today, or we should be, but it strikes me that Scotland is a lovely natural experiment for this, in that since just to blow the trumpet of Alzheimer's Scotland and the Scottish government for the wonderful things they've done, since 2013, everybody diagnosed with dementia in Scotland is entitled to a minimum of a year's post-diagnostic support by a named link worker, which we won't go into the details of how that is variably implemented, but it's there as a commitment, and it does mean that lots of people get a good amount of support after diagnosis, whether or not they have any medication, because the difficulty in many services is that you get a lot of support post-diagnosis if you are prescribed medication, and you don't if you're not suitable for a cholinesterase inhibitor, you're often discharged. So Scotland would provide a lovely natural experiment, and Lucy, you might want to note this down as a potential project, because you could compare the people who didn't get prescribed medication, but who are likely to have received hopefully comparable amounts of support, to see if there are any differences in outcome between those two groups, because that would certainly give you some indication whether or not this is a medication issue, or whether it's just because this person's got a lot of support and input around the time of the diagnosis, which would be easier than starting to think about the biological mechanisms, which, given that we've only got about 30 seconds left, is probably more challenging. But I think it says something about the state of the art with treatments for dementia, that the licensed treatments we have work with acetylcholine, when actually all of the research focus is on different mechanisms. So I think that we're a long way from understanding what dementia is the gnomic comment I'd choose to finish with.
Brilliant, thank you, Tom. And I think in view of time, we are going to have to call it a day there. Lucy, I'll hand over to you to wrap up from Edinburgh.
That's great. Thank you very much to everybody on presenting and on the panel for your thoughts. And I'm only sorry we couldn't have talked for longer, because I think there's a lot more to say. Thank you very much, and thank you to Angharad and the BJ Psych for co-hosting and supporting us with this, and who had the idea in the first place.
Oh, brilliant. And I'd like to say thank you as well to everyone at the University of Edinburgh for hosting us today, and everybody from BJ Psych who has been supporting us in the wings. And thanks again for coming today, and do join us next time for the next Journal Club. And we wish you all a very good late afternoon, and goodbye from all of us.
Thank you.